All right. Good afternoon or good morning, as the case might be, as you are joining this webinar. We'll give it a minute or so to allow some other attendees to join us. I see a number of folks joining the waiting room. Happy to see some familiar faces, some familiar names at least. Really appreciate you joining us for this fifth webinar in a six-webinar series, Advancing Data Policy and Prevention for Service Members, Veterans, and their Families. See some folks joining. All right, looks like we've slowed down a bit. So we'll go ahead and get started. As I mentioned, very glad that you are joining us for this fifth in a six-webinar series on advancing data policy and prevention for service members, veterans, and their families. Today, very specifically, excited to talk about suicide risk prevention and the veteran suicide prevention landscape with a couple of our colleagues from RAND. Next slide, please. My name is Duane France. I co-lead SAMHSA's Service Members, Veterans, and their Families Technical Assistance Center, and I am proud to be your moderator for today's session. Next slide. SAMHSA leads the public health service delivery efforts that treat mental illness, especially serious mental illness, prevent substance abuse and addiction, and provide treatments and supports to foster recovery while ensuring access and better outcomes for all. So very proud to be part of the work that SAMHSA is doing. Since 2008, they've partnered with states and territories serving service members, veterans, and their families, providing technical assistance through the SMVF TA Center. Next slide. Some of the ways in which the SMVF TA Center provides technical assistance, you can see there. You can access our website through the QR code or for the SMVF TA Center on the SAMHSA website. We do a number of different things. Some of them include webinars, but also support training of SAMHSA stakeholders and grantees, identify resources, supporting planning implementation of interagency teams, and provide technical assistance, training tools, and consultations. So always willing to provide support to SAMHSA grantees related to service members, veterans, and their families. Next slide. Again, some of the technical assistance methods that we have is policy academies, implementation academies, and other events. We just wrapped up an event this past week and are preparing another event in several weeks. Crisis intercept mapping webinars, learning communities, communities of practice, TA calls, and on-site and virtual expert consultation, as well as developing some toolkits for SAMHSA, all with the goal of supporting you in helping service members, veterans, and their families to achieve mental health and wellness. Next slide. Very proud to be able to partner with RAND on this six webinar series. Again, this is the fifth of the six webinar series. RAND is a nonprofit research organization that helps improve policy and decision making. We have been proud to have partnered with RAND for a number of years, but especially to be able to bring you some of this work and their expertise. Their expertise includes, of course, not limited to behavioral health researchers, survey methodologists, epidemiologists, health economists, statisticians, data scientists, clinicians, and much more. Next slide, please. This series is one that we have been sharing some of the publications that RAND has developed specifically for service members, veterans, and their families across the military to civilian transition. This series explores how data research and policy insights can inform more effective programs, services, and prevention strategies at the national, state, and community levels. You can access all of the previous recordings as well as sign up for one more session in this webinar series, but you can access that through the QR code. Next slide. Today's learning objectives, as you can tell by the title, obviously on suicide risk prevention and veteran suicide prevention landscape. We really hope to support you in identifying key risk and protective factors for suicide among service members, veterans, understand how these factors interact during the transition, Applying evidence-informed strategies and data sources to improve prevention planning, outreach, and coordination across military, VA, community systems, and supporting SMVF populations. Describing approaches and combinations of approaches being used in suicide prevention for veterans, and describe emerging approaches towards suicide prevention. As you can tell, you will be able to communicate to us, the webinar hosts, through the question and answer pod. We will be able to answer any questions that you might have. We will also have an opportunity to have questions and answer after the presentation has ended. You would not be able to use the chat, and if you want to ask any questions or further information, you will do so through the Q&A pod. Next slide. Our presenters today are Dr. Lynsay Ayer and Dr. Lynsay Jaycox. Dr. Lynsay Ayer is a senior behavioral health scientist at RAND. Her research focuses on improving the effectiveness of and access to suicide prevention programs, especially for high-risk populations, such as military service members and veterans. And also Dr. Lynsay Jaycox, a clinical psychologist and senior behavioral health scientist at RAND. She has extensive expertise in the development and evaluation of mental health programs, including suicide prevention, and has done work related to mental health and suicide prevention amongst service members and veterans. Next slide. So at this point, I will hand it over to Dr. Ayer.
Thank you. Happy to be here. We can go to the next slide, please. So I'm going to give a little overview today of the rates of suicide among veterans, high-risk groups, and what might be working to help prevent suicide. Next slide, please. Just a note first about our Veterans Policy Research Center at RAND. We have the Epstein Veterans Policy Research Institute oversees work that aims to improve the lives of those who served and those who support them. So we have, as Duane mentioned, a series of research projects and commentaries, and you can go to our website to find all of those. They're free to you. Next slide. So today I'm going to start by talking about the problem of veteran suicide and its scope. Then we'll talk about some high-risk populations and why they might be at risk. And then we'll turn to some promising advances in veteran suicide prevention that are being overseen by VA and its partners. And then we'll end by talking about future directions, so areas where we need more attention, whether through research or practice or innovation. Next slide. So starting with the problem, let's go to the next one. Overall, just a quick caveat is that these slides were produced when we just had 2022 data. And so there have recently, the 2023 data have come out. As you could tell, suicide data are lagged. There's a several-year lag in when we get the data. So based on 2022, there were over 6,000 veteran suicide deaths. And the suicide rate is 34.7 per 100,000 among veterans, which is twice as high as the rate among non-veterans, which is 17 per 100,000. Importantly, almost 3/4 of veteran suicide deaths involve firearms. So you'll see a theme throughout this talk that this is a focus of the VA and other veteran serving organizations. Next slide. Looking over time, over the past couple of decades, veteran suicide rates have not only been consistently higher than non-veteran suicide rates, but they've also been increasing at a faster pace. So you can see here, these red and gray lines represent veteran and non-veteran suicide rates from 2001 to 2022. And what they show is that the veteran suicide rate and non-veteran suicide rate started much closer together than they are now. That gap is widening, and that's really concerning for us, those who are concerned with this population. Next slide. All right, so when we think about who's most affected, we get some hints from the latest suicide report. And it shows that those who are in the younger age range for veterans, 18 to 34, have the highest rate of suicide. So they're at the highest risk. However, because of the demographics of the veteran population, those 55 and older account for the highest number of suicide deaths. So 55 and older accounts for 60% of all suicide deaths. There's also some interesting differences by sex. So we see that female veterans are 92% more likely than non-veteran women to die by suicide. That's pretty striking. Male veterans are also much higher risk than non-veterans, but to a lesser extent. So they're 44%. Their rates are 44% higher than non-veteran men. And then we also see, perhaps not surprisingly, that mental health and substance use disorders are a big risk factor. So veterans who have those types of disorders are at about twice the risk of those who do not have those kinds of disorders. And here in little font at the bottom of the slide, you can see the most common diagnoses among suicide decedents were depression, anxiety, PTSD, and alcohol use disorder. Next slide. So let's talk a little bit more about high-risk subpopulations beyond those demographic characteristics I just shared. Next slide. Military sexual trauma is a consistent risk factor for suicide in veterans. We see a rate of about 25 per 100,000 for those who've been military sexual trauma victims compared to 14 per 100,000 for those who are not. Among male MST survivors, it's even higher risk, much higher risk, where 75 per 100,000 is the rate for them. And remember, the overall veteran suicide rate is around 34 per 100,000. So this is a substantially elevated rate, especially for male MST survivors. Next slide. We also see that veterans who recently separated from the military are at pretty high risk for suicide, relatively speaking, and that suicide risk rises throughout the first year post-separation. So this gives us a clue that that first year of transitioning from the military to veteran status is a really critical time where we could be doubling down on our suicide prevention efforts and suicide risk detection. Next slide. And then it turns out, potentially not surprisingly, that those who use VA care are at lower risk than veterans who are only getting their care out in the community. The VA has a very robust suicide prevention infrastructure and set of programs. And in the community, it's going to be a little less consistent across communities. So that could certainly be part of it. But also community care users veterans who are community care users tend to be lower income compared to VA users. And that's another factor that we'll consider in just a minute. Next slide. Other than honorable discharge is also a risk factor. So those who were discharged from the military with other than honorable status are twice as likely to die by suicide than their veteran peers who are honorably discharged. Next slide. And then revisiting this potential income-related risk factor, there are VA priority groups. For those who are not familiar, these determine enrollment priority for healthcare benefits. And VA Priority Group 5 represents veterans who are low income, Medicaid eligible. And as you could see here in the red line, they are consistently at higher risk for suicide compared to other priority groups. We also pulled out Priority Group 1, which represents veterans with service-connected injuries, and they are also at higher risk than other groups, but not as substantial risk as Group 5. Next slide. All right, so given who we know is at risk based on the data, um, we will now talk about what VA and its partners are doing to try to combat that risk and reduce veteran suicide. Next slide. Here we're just going to highlight 6 VA programs that are pretty well known and robust throughout VA. This is just a small sample of VA programs that are working on this issue. And if you want to talk more about that, I'd be happy to at some other point. Just to briefly tip of the iceberg, Risk ID is a universal screening program where all veterans who receive care in the VA get screened annually for suicide risk. And this has been going on since 2020. Less than 5% screen positive. Those who do screen positive then receive further assessment and connection to mental health care. And that program is proving to help make those connections and ensure those at risk are getting services that they might need. ReachVet is another way of identifying veterans at risk, but this one is a predictive algorithm that uses VA data like medical records to identify the group of veterans who are at highest risk. So the top 0.01% of highest risk veterans. And those veterans, it's been shown, have 39 times higher suicide rate. So this seems to be a decent tool for predicting who the group of veterans who might be at risk. I will say it's not perfect. There are issues with any predictive algorithm for suicide. But VA has been a leader in this, and they are taking this information and it sort of triggers additional outreach from providers at VA and more frequent monitoring and follow-up for this group of veterans who are at risk. The Caring Contacts program is another one, definitely being implemented beyond VA settings. It's in a lot of different medical healthcare systems now. But basically, the idea is when a veteran is at risk for suicide, which could be identified in a lot of different ways. Maybe they call the Veterans Crisis Line or they show up at the emergency department. There's a follow-up with just brief messages of support from the providers in that healthcare system to check in on the veteran, let them know that there's someone out there who's thinking about them and who cares what happens to them. And through a randomized trial, it was shown that Caring Contacts helped participants be more engaged and use healthcare afterwards. So it helps make sure those veterans at risk aren't lost or falling through the cracks. Next slide, please. The other 3 programs we wanted to highlight also touch on some of those risk factors we showed earlier. One is a whole slate of initiatives that VA runs related to firearm safety, and this includes distributing gun locks, an ad campaign, pretty big media, an ad campaign, keepitsecure.net, that hopes to educate and increase awareness of firearm safety. It involves peer counseling, lockbox distribution, a whole set of activities that are trying to reach veterans at risk in a lot of different ways. Again, because 3/4 of veterans who die by suicide die by firearm. And then to address this issue of the veterans who are unaffiliated with VA, those community care users, the VA has helped to support some pretty major broad investments in communities to help local organizations that are not affiliated with the VA to engage with veterans who might be at risk, support them, and then also sometimes connect them with VA if possible for additional care and follow-up. But it's intended to help build more of a coalition between VA and community partners to help identify veterans at risk and prevent suicide. Mission Daybreak is another example of a similar type of effort where VA is partnering with other organizations in the private sector to try to identify other ways to prevent suicide. Next slide. And then other examples of VA partnering that I'll just mention three, but these are pretty big ones that a lot of you probably are familiar with. The Governors and Mayors Challenges, where VA and SAMHSA work together to provide resources for state and city multi-component interventions. Community engagement coordinators are VA staff who go out into communities and work on, for example, risk identification, means safety, safety planning, things like that. And then Face the Fight Coalition is something that my colleague Lisa will talk about more in the next presentation. But this is a coalition of corporations, foundations, nonprofits, and veteran organizations that are working together to raise awareness, fund prevention, and reach veterans, again, outside those VA settings. Next slide. In terms of what's next, let's go to the next slide. There, as shown just on the prior few slides, there's been a lot of investment and effort put toward reaching veterans outside the VA, and that is completely warranted because of what we see in terms of veterans at risk who have no VA encounter in the year prior to their death, and also um, the much higher rate of suicide among those who are in community care and not engaged in VA care. And so we might need new models to reach unaffiliated veterans. That's still something that VA and other partners are figuring out. Next slide. There's also some evidence that there could be better tailoring of interventions for certain subgroups. So for these populations like MST survivors or recently separated veterans, other than honorable discharge holders, they have really specific needs potentially just because of, for example, that recently separated group is sort of in limbo, but switching between different healthcare systems and dealing with all the stress and adjustment that comes with that process. And that might be a specific circumstance or set of stressors that needs to be integrated into our existing evidence-based programs. It may not mean creating brand new programs. It could be tailoring existing ones. Next slide. And then we really need to figure out more about this link between low income and suicide risk. Right now, there's an association, but we're not totally sure about whether it's a causal one. That, for example, having financial instability or distress causes suicide risk. There's a lot of other potential confounders in there that could also explain that link. So we need to understand that better. And then, as part of that, understand whether economic policy changes can help reduce veteran suicide. Next slide. And then regarding this effort to expand veteran suicide prevention further outside VA into community programs, This is a tough evaluation effort to do. It's hard. It's hard to evaluate programs on suicide prevention in general because we have a relatively rare event. Thankfully, suicide is relatively rare, but it's hard to detect changes as a result of a program in a timely manner with the usual size of populations that we're dealing with in community settings. So it's a challenge, but we really need good data, for example, on these ongoing efforts in order to see what works and for whom. Next slide. And then finally, there has been a lot of innovation lately on novel treatment approaches. Ketamine is one example. There's been a lot about psychedelics, just-in-time adaptive intervention with real-time monitoring. So definitely we need to keep thinking outside the box and expand our concept of how and where and for whom we're preventing veteran suicide. So I think that's my last slide. Dwayne, I can turn it back to you.
Yes, thank you. Next slide. For those of you who are interested in connecting with Lynsay, you can see her contact information there. Thank you so much, Lynsay. We definitely feel like it's important to be able to share some of this baseline information to make sure that we're all looking at the same data and understanding the same thing. So very much appreciate you and sharing your subject matter expertise. Next slide, please. Now we will turn it over to Dr. Jaycox, following on Lynsay's presentation to talk about some of the things that are working for this effort. Lisa.
Thank you. I'm going to be presenting today on a study that we completed last year, looking at the community-based programs that are available to veterans related to suicide prevention. The lead author on this project was Rajiv Ramchand, who's out on medical leave, but I worked on the project, and so I'll be trying to represent us here today. Next slide. So these numbers, Lynsay just presented a bunch of different numbers, but here is looking at it slightly different way with the data going up to 2023. So these are the light blue lines are female veterans and the darker blue lines are male veterans. Sorry, the solid lines are veterans and the dotted lines are age-adjusted counterparts who are non-veterans. And you can see the data just in a slightly different way that both men and women are at higher risk with the veteran status than their non-veteran peers. And like Lynsay said, the gap is increasing. Next slide. Because of this problem, there's been a lot of development of a huge array of different kinds of services in the community with a lot of different players. There's the National Veterans Crisis Line that is available to everyone free of charge and connected to 988. There's the grant programs, media campaigns, family outreach and support, as well as training programs. And so because there are so many different things, it's hard to kind of get a grip on what exactly is being offered to veterans outside of VHA, and that's what this study is about. Next slide, please. So this study was funded by Face the Fight Charitable Foundation, which is part of USAA and supported by this coalition that Lynsay mentioned a few minutes ago. And what we sought to do was to look at what approaches or combinations of approaches are most effective based on the literature. Are those veteran suicide prevention efforts in the community coordinated, duplicative, what's out there basically, and are all veterans being reached equally? And also looking ahead, we looked not only at existing programs, but grant applications to Mission Daybreak to look at what people were interested in doing in the future, what kind of funding was being sought for new efforts. So next slide, please. What what we found was we did web scraping across the internet to look at specific programs that were being offered to veterans and with a suicide prevention goal. So that's not including programs that might mention suicide rates on their webpage, but have a more general mission that had to be really a specific aim towards suicide prevention. And we found 307 programs in total, with 156 of those being current programs out in the community that have a web presence. And then 228 of the proposed programs that I mentioned were pitching studies to for Mission Daybreak funding, and we're hoping to develop suicide prevention activities along those lines. So that kind of gives us more of a glimpse of what might happen in the future versus what's being offered right now. Next slide, please. So looking across all of those, our team categorized 26 different activities, types of activities. You can see all kinds of things on here, from pharmacotherapy, meaning medication, clinical practice guidelines, clinician training. So our team categorized the activities that we found via the web searching and through the proposal analysis to try and understand what different activities were being offered. And then we look at the evidence that is available for each of those. And so you're going to see all of that in our report. There'll be a link to the report at the end of the presentation. But I'm just going to walk through a few examples right now to give you a sense of what's out there. So next slide, please. Oh, first I'm going to talk a little bit about how we organized it as well before I get into the examples. We first sought to look at who is served by these different programs. So it could be the veteran, him or herself, the community around the veteran, or a broader approach to all of society. And then in the next slide, on top of that, we looked at the type of risk that was being addressed through the program activities. So this is kind of a classic public health kind of triangle, looking at ways to target activities towards different levels of risk and different reach in terms of who's served. But we modified it for this, and we're calling it the RAND Suicide Prevention Activity Pyramid. So you can see at the top, for the fewest number of people are those who are actually in crisis at the moment, and for whom a crisis response is most appropriate. Below that is mental health crisis response, which is kind of a blurry area between the mental health programs and the crisis response, where perhaps someone is in an acute stage of a mental health problem, not necessarily at imminent suicide risk, but they're partway there. Below that are mental health supports that might help someone cope with a mental health problem. And below that, more general well-being kinds of activities. And then we called the bottom layer primordial, sort of the kinds of activities that are good for the entire society that can help reduce suicide risk overall at the population level. So next slide, please. So we kind of classified how these 26 different prevention activities fit into that matrix. And this is going to be too small to see. It's 2 pages in our report, so it's hard to fit on one slide. But you can see that crisis response to primordial kind of activity on the left, and then the 3 colors of blue represent the veteran, the community around the veteran, and society as a whole. And most of the prevention programs that we found in the community are focused either on the veteran or community level. As you can see, that's where most of the activities are. And some activities span multiple levels, things like means safety, where there's training in how to restrict access to lethal means, or teach people how to be more safe when they have a gun or have access to medication or that kind of thing. So this is just a way for us to organize all the different activities. We were trying to look at coverage, basically. Are there gaps in this matrix? Are there things that really aren't being addressed? But you can see that we found different kinds of activities at most of the levels that focus directly on the veteran and on the community around the veteran. Next slide, please. So this is where I'm going to get into some of the examples. I'm going to go through 3 different ones that were the most common kinds of activities that are being offered in the community. Those are social connection building, case management, and non-crisis psychological counseling. So that psychological counseling that comes below the crisis level that's applicable to people who have a variety of different mental health problems. So we'll start with social connection building. If you can go to the next slide. What we did for each of these, the way the report's organized is for each of these types of activities, we talk about the definition, the evidence in the scientific literature for that type of suicide prevention activity, and then other considerations that are important in sort of thinking about why this type of service should be offered. So for social connection building, the idea is that you're bringing veterans together so that they can build social support and get more support in their lives. So that could be a shared experience like, hiking trip, bonding, camaraderie. And the evidence for that is not, there's not a lot of studies that show that is those kinds of programs are effective in reducing rates of suicide. But on the other hand, there's a very compelling rationale for this type of activity because we know that social isolation is one of the big risk factors for suicide. And so anything that you can do to decrease social isolation and increase social support should be helpful. So you can see this is the kind of thing that we discussed. Just because there's not evidence doesn't mean that that type of activity might not be valuable. And in fact, it's really hard to demonstrate effectiveness for suicide prevention, partly because of the rarity of the outcomes, but also you have to look across a long period of time. You have to have a control group, which can be unethical in many circumstances. So it's really hard to build the evidence. So just lack of evidence doesn't mean it doesn't work. It means maybe it was hard to study or that we haven't been able to study it well yet. And so the other considerations can kind of help balance what we find in the evidence category. I'll go to the next example. Next slide, please. So case management is another very, very common activity that's being offered in the community. The definition really is taking a veteran at risk and trying to connect them with resources, including mental health resources and peer support networks. And although there aren't that many that support that kind of care coordination on its own, like the actual care coordination piece, the exception is when those kinds of care coordination are embedded within a system that is offering good care to the veteran. So if it's within a system where the veteran can be effectively linked to high quality treatment, then there is better evidence for that. And that's some of the work that VA is doing around primary care coordination for individuals at risk. There are good studies about that. Again, other considerations, case management or care coordination is really a common element, and it kind of spans between the risk screening, which is also talked about in the report, and the kind of care that is happening in counseling and that can be offered that we know are proven treatments for suicide prevention. Next example, next slide, please. So now we get to the actual psychotherapies, types of treatment that are not at the crisis level. So it's not when somebody's at imminent risk, but more dealing with a mental health problem. And there's a whole variety of different types of treatment that are available. Most of them are in the cognitive behavioral kind of realm. But they also include very suicide-specific things like safety planning. And there is evidence for those kinds of approaches working, that there are small but positive effects on reducing suicide thoughts and behaviors. And many of those studies include veterans. So the other considerations, this is an example where there is some good evidence that these approaches work, but the trick is getting people into the treatment that when they need it. So access to these services can be difficult, particularly outside VHA, where the quality of and the type of services is less guaranteed than it is within BHA. Okay, I'm going to move to the next slide, emerging types of technologies. So this is where we're looking more at what kinds of ideas people have for the future and are trying to seek funding for, which are a different set of activities. So here the three very common ones that I'm going to go through are real-time monitoring, new risk assessments, in addition to the ones that we already have, where you're basically asking somebody about their thoughts and behaviors, and multifunctional digital health platforms. So I'm going to walk through a few of those. And again, there's more of these in the report, but this is just a taste. So real-time monitoring is where companies are trying to leverage biometric data, cellular data, wearable technologies to monitor mental health status in real time and alert the veteran or whoever is caring for the veteran that an intervention is needed if those are showing some risk variables. So we know that there is some evidence that these can detect elevated times of distress, but what remains to be seen is how you compare the risk detection with a type of intervention that's tailored to the individual. Some of they're called just-in-time adaptive interventions, and Lynsay touched on that earlier. So the technology is tricky, and there's a lot of studies going on this topic area, but we don't really have evidence for it yet, and it seems to be very dependent on the health system and the tracking system and the technology. So this is an area that could be fruitful in the future, but it's not quite there yet. Go on to the next one. Suicide risk assessment. So the old way of doing this, the traditional way of doing this, is to ask a person about their thoughts and feelings and behaviors, and use that to score a risk level. And then usually to follow it up with a more thorough assessment if their screener on a questionnaire shows that they might be at risk. But there's more technology advances here, enabling assessments to be completed without talking directly to the individual in that way. And a couple examples, well, the one that's very prominent is ReachVet, that actually analyzes all the data from VHA electronic health records and looks for people at statistical risk. So these are not people who are necessarily talking about their risk, but from a statistical perspective are going to be at higher risk. And therefore, VA can reach out to them and talk to them and screen them, even though they're not necessarily reaching out for help at themselves at that moment. And next slide. Finally, these multifunctional digital health platforms are trying to bring some of these evidence-based components from the psychotherapy literature to a digital telehealth kind of platform where you can get connected with real clinicians trained in evidence-based therapies. You can get education about suicide and firearms safety. There's crisis intervention resources. So it's sort of one-stop shopping for all different kinds of things that might be helpful. And again, this is a sort of a popular idea, but hasn't yet been really fully developed. And the problem also is that even when something is developed and might have really good resources attached to it, veterans don't always know about it and don't always reach out to it. So we find that sometimes these tech solutions seem to be quite good in incorporating all the latest information and evidence-based therapies, but they're not used to the degree that would be desired. So that'll be an important thing to figure out with research going forward. Based on all this data, we came up with some recommendations in terms of sort of where we see possibilities for things going. I mean, the obvious one, go to the next slide. Actually, go 2 slides. Oh, I guess I didn't say next slide enough. Sorry about that. Go one more and one more. Thank you. Okay, so the obvious recommendation would be to prioritize the evidence-based prevention strategies because we know that we want to give people a chance to experience a therapy that can be helpful to them or an activity that can be helpful to them. And false starts can kind of turn people off from help seeking. So we want to make as much as possible these kinds of interventions available. So those would be community-based prevention activities, suicide risk assessment, the mental health services of both crisis and non-crisis variety, and also medication or pharmacotherapy. So those are the things that we know work best, and as much as possible would encourage those to be offered to in community settings. Next slide, please. The second recommendation is consider the context. So even if you have the best proven therapy, evidence-based therapy, it may or may not be attractive and acceptable, feasible to get that therapy in that setting. So if you can reach veterans where they are in a setting that they're comfortable in, for instance, that could be much better than having it in a clinical setting. So there's efforts to bring these kinds of activities into churches, into vet centers, into community settings, such that there's less stigma and the person's already comfortable being, being in that setting, such that treatment is easier to get. And for some people, that might be a telehealth kind of platform, the context, but not always. And there's a lot of research needed to sort of understand who does like the teletherapy kind of context and who would prefer one-on-one and where and all of that thing. All of those things really matter. Next slide, please. Finally, well, not finally, another recommendation is to conduct a needs assessment to try and sort of identify gaps in prevention activities, particularly in certain locations. So if you have a city and can really look across the area and see what is there and what's not there, then it can help prioritize what needs to be filled in. So even though some overlap makes sense, you want to give people choices, there may be important gaps to consider at the local level. Next recommendation, next slide. It's all well and good to talk about implementing evidence-based therapies, and that's always been a big emphasis in my work and in Lynsy's work and in Rand's work to make sure that we're having high quality care whenever possible. But there are going to be times when it's worth taking more of a risk, either because treatments haven't worked for an individual or there's sort of a more urgent need to try something new. So one of the things we have in our report is a sort of flow chart to think about when it might be make sense to deviate from the solid evidence base and try an innovation for either a new group of people that are at risk where the existing evidence-based therapies don't work, or an emerging problem of some sort where you need to sort of ramp up the effectiveness of something, and it's where it's worth taking a risk to try something new. And then next slide, invest strategically in research that fills the knowledge gaps. So we did go through some priorities in the report around research. We always like at Rand to talk about what research would be helpful for the field because that's our main activity at Rand. So randomized controlled trials, but not just randomized controlled trials. You really need the long-term follow-up because it takes a long time to be able to observe any effect with most people being at low risk and suicide deaths in particular being rare events. Designs that link interventions that change knowledge, attitudes, and behaviors. So people are going to cycle through different interventions. They're not necessarily only going to get one intervention at one point in time. So thinking about ways that you can make linkages and look at trajectories would be helpful research. Looking more at mechanisms of change. So for example, we kind of talked about that earlier with the social connection programs. If you want to really decrease social isolation, which we know is an important risk factor for suicide, then you could look at that specifically, look at the mechanisms that different activities are doing and whether they're actually changing that sense of social isolation. Similarly, precision medicine research, which is really trying to tailor the existing interventions to a particular individual to see what works for whom and when. Bringing in multifaceted interventions and testing those. And then there's always a lot of ethical considerations for testing out different suicide prevention strategies because we need to try to help everyone that we know to be at risk, but it's hard to do the research if you don't have any kind of control group. So there needs to be just more work and more consideration for how we can improve research without compromising any ethical issues. And finally, there's been good strides in changing thoughts and attitudes towards suicide, knowledge about suicide, and sense of community that could be really helpful, but we don't know if they are sustained beyond sort of the period of the activity to promote those. So for instance, there have been some zero suicide programs that have shown good short-term effects, but when the real focus on activities ends, that it kind of drifts back to the way it was before. So we don't see the sustainment yet. So that's another research challenge. Then I'll just go to the final slide. This is where the report is. You can take a picture of the QR code, or you can just go to Ren's website and search for the title. It's free download, or you can read it online. And that is the end of my prepared talks. I think I've seen a lot of questions going into the Q&A, so I'm ready for that.
Yeah, absolutely. Thank you so much, Lisa. And yes, so I dropped the link to that, and thank you, Lynsay, for dropping the link to the publication for your portion of the presentation. Aaron, next slide, please. So yes, we've had a number of different questions come through, and for those of you who are attending, we do have a bit of time left. So if you would like to ask some more questions, please do. I think this is a common question that we frequently get is why does it take so long? Sort of the lag in the data that comes from the several years that it takes for suicide death data, not just for veterans, but nationally. So I'm wondering if either or both of you would be able to speak to the reason for that lag.
I could talk about that. So there's a challenge in especially getting the rates of suicide for veterans because veteran status isn't necessarily known, although everyone's trying to work on improving the data. But basically what happens is when somebody dies, a local coroner codes the cause of death, and then that goes up to CDC and they compile a national death index on a yearly basis. But it takes a while to verify the information. Sometimes records take a while to come in, including especially sometimes suicide deaths, because it takes a while to figure out how to code it, whether it was a suicide death or an accident or some other cause of death. And that all gets rolled up and verified, and it lags. It takes a few years to get out a certain, calendar year's data. And then for the cataloging the veteran deaths, then there has to be a matching that goes on between known Social Security numbers of veterans and people who appear in the National Death Index, and that takes time. So it's a big analytic challenge, and it's definitely makes it harder to look at real-time changes, but it's something we all have to live with at the moment.
Yes, absolutely. Thank you. Lisa, another question that came in for your part of the presentation is talking about some of those social connectedness efforts. And really, I think you addressed it briefly, talking about how one might measure sort of the social isolation aspect of these. But the question is really identifying some of the anecdotal evidence of these programs. They've saved my life. They've really helped me out, but there's no clear universal way to measure that. And if you have any other innovative ideas, but I think definitely talking more about perhaps measuring that social isolation component.
Yeah, it's always a challenge to measure things that are these kinds of mechanisms and internal factors. There's just like issues with developing the questionnaire that really gets at the issue, clearly and reliably. But I think one of the challenges for this type of program is, first of all, it's not for everyone. So people gravitate towards it that might want that kind of activity. So there's some selection that goes on. And then it's the same issues I mentioned before with difficulty figuring out what a control group would be because people's risk is changing over time and can be very fluid. Um, and how you would look far enough out to see whether the program is actually having an impact compared to somebody who wasn't in the program. So it's all very challenging, but I like the fact that the anecdotes, are important, and qualitative research can be really helpful as well to understand interview people and get their impressions of things and understand what their experiences were in the program. Lynsay, you might want to say more on that one.
No, I ditto.
It's really hard to code stories, right? If someone is sharing their story and even their own personal experience and how meaningful it was to them or those that were around them, and like you said, how you um, quantify qualitative data and qualify quantitative data is definitely a challenge. Um, there's a question from our colleague in Hawaii, Renee. Thank you for joining us. Ask about recommendations from a state policy perspective on how to reduce suicide for service members, veterans, and their families based on your research. Really, you were talking about organizational impacts, but what could be some perhaps state level policy impacts that might be understood based on some of the data?
I can try for that to answer that one. I think here there are things states can do that would help everybody in the state, including veterans. One is some states are starting to have mandatory training for example, their mental health clinicians. Anyone licensed in the state needs to have training in suicide risk assessment and evidence-based prevention approaches. So that's one thing, is setting policies that try to elevate the quality of care being provided. That might be especially important now that the VA is encouraging and sort of incentivizing community care. And so for veterans to get community care instead of just VA. And already most veterans do get their care from the community and not VA. So that's one role for the states. Uh, I think generally, if especially if you have a certain knowing certain if there's certain regions in your state that have a lot of veterans or service members, then you might consider talking with veteran serving organizations that are working in that community and seeing what they're, asking about what they're observing. And I think as we talked about earlier, the needs are gonna depend on who the veterans are. For example, if they are mostly a lot of new folks who just transitioned out of the military, their needs might be different than if if your community involves more like Vietnam era veterans. Lisa, do you want to add anything?
Well, I might even kick it over to Duane because there's also like the data issue, which is trying to really get good mortality data at the state level. And there's suicide mortality teams in many states. And Duane's organization is providing a lot of technical support and convening people so that they can learn from one another. Because then you could start to notice areas of concentrated risk, what's happening in the rural areas, and it really comes back to the person conducting the autopsy and doing that rating. And then these suicide mortality teams are trying to meet on a regular basis to look at the data and identify things that might be a problem and things that they could do about it very specifically. I don't know if Duane, you want to say more?
Yes, thank you. And I think that even goes back to that data question that was earlier is suicide mortality review or suicide fatality review teams can definitely provide more accurate data. Still the same challenges as far as identifying veterans and how that process is. But suicide mortality review teams can identify dynamic risk factors, so risk factors that might be unique to a particular community or a particular state. As we know what the static risk factors we've heard today about isolation and characterization discharge, for example, in the military and veteran population, but what are the dynamic risk factors in a particular community that being able to engage that data sort of laterally as it's going up to the CDC and the federal government, being able to identify that. But definitely, I think there's opportunities, whether legislatively at the state level, to be able to provide some funding or support for some of these different data exploration that we talked about today, or even without the legislative and the executive branch of the state, some policy efforts to be able to support some of this. So definitely appreciate that question.
Also, I see another question in the chat that is related to this too, about sort of upstream factors related to employment. We've seen studies of minimum wage, so financial issues and poverty, and you can see some trends of reduced suicide with increased minimum wage, for instance. So a state could also be looking at those upstream factors around housing, employment, poverty, or the reverse, and trying to make those social determinants of health better for everybody, such that you could potentially see a reduction in suicide.
And I'll just one more note on this. I'm just going to put a link in the chat to American Foundation for Suicide Prevention has state fact sheets that show what different states are doing around suicide prevention. So this is not specific to service members and veterans, but just in case anyone's interested, I'll put that in the chat.
Yes, thank you for that. And I think some of this, and you mentioned it a couple times today, is suicide prevention programs that work for everyone will also include necessarily the veterans, right? So it does not need to be exclusive to veterans, but it can in fact include veterans as a member of the population. We had a question come through talking about the challenge of self-identification for veterans. The question is really about what is the estimated percent of unaccounted suicide by veterans, but I think that question really indicates that even the numbers we have is the tip of the iceberg, based on not all individuals who die by suicide identify as veterans or even acknowledge their own military service.
Yeah, so there's self-identification of the veteran status, and then there's also self-identification of the suicide risk, right? And I'm not sure exactly what the question is intended to do, but both are issues. So, I mean, again, people collecting data are trying to ask about veteran status more regularly. So there, like, I won't be able to go through all the different, major data collection efforts, but that is getting included more. But if it's not necessarily available, and sometimes when you enter psychotherapy, for instance, it's not on the intake form. So like it's not necessarily known unless you do self-identify. And then another challenge is the risk screening. You ask 4 or 5 questions about suicide risk, and people might not want to self-disclose on that form either. There's especially people who have prior military experience, like veterans. They kind of know what happens when you say yes to those items, that it's going to probably lengthen the appointment at least. Maybe some interventions will kick into gear, and sometimes you're not, time isn't right to do that on a given day. And so people could say no, no, no for several visits before they decide to say yes. And that's always going to be a challenge. Sometimes people don't self-disclose until they're much farther along the crisis continuum and needing more help, and might choose not to when it's more uh, less severe, and but they could still use help at that earlier. We're trying to get the activities earlier and earlier so that people don't get into a crisis situation. But the other part of the question, the estimated percentage of unaccounted suicide by veterans, that's a really tough one. The VA does put out an annual suicide prevention report that does its best with the data, but there's data issues of various types. Some of them we've talked about, and some of them we haven't. There was a fire that destroyed records for many, many people, that has affected our ability to estimate these things. So there's a lot of different data issues.
Absolutely. Thank you for that. There's another question that may have been another tricky one or a broad one, but really talking about the differences in risk between currently serving full-time active duty military, National Guard or Reserve members, who these days many times are almost full-time themselves, but definitely have a different structure, and veterans. And maybe I'll even expand that, but even veterans of different eras and different service in those things. And each of those different factors has their own unique risks.
Yeah, you can definitely see risk among active duty in the different services. So that's clear. And I do believe there's also good data on active duty versus National Guard Reserve. But I don't know that I've seen those same numbers compared to veterans post-service. Do you know, Lynsay?
think I think it's difficult because veterans demographics are as an entire population are going to be quite different from, for example, active duty military. I was just looking, I'll put it in the chat. The DOW suicide report does look at Guard, Reserve, and active duty, and there's different suicide rates. So that those are more comparing apples to apples in terms of demographics, at least. I think it would be more difficult to compare to veterans, because they tend to be older and a whole variety of other things.
Absolutely. Thank you. We just had a question that come in, I think, talking about perhaps the complexity of sort of exposure to trauma. A question about, and I would think is, do you see more stress or perhaps crises in veterans who are serving as first responders, firefighters, and police? My father was a Vietnam veteran and left Vietnam, became a St. Louis City cop in the 70s. So we didn't know where one ended and the other began. But maybe that question about sort of complex trauma and ongoing exposure to trauma for our service members who then go on to be first responders.
Yeah, I can say a couple words about that, and Lynsay can say more. There is definitely good evidence that traumas don't make you stronger and immune over time, but rather the reverse, that the number of traumas do stack up and make people more susceptible to a mental health problem like depression or PTSD, an anxiety disorder. So we know that, and then mental health problem does put you at increased risk for suicide, but there really aren't any great predictors of who might die by suicide. It's none of the risk factors are highly predictive, so they all have sort of low predictive value for looking at who might actually be at risk. Um, so I'll start with that, and then Lynsay, do you want to say more?
Yeah, I mean, I think we see a lot of veterans in those professions, self-selecting into those professions for a lot of reasons. But yes, agree that the trauma compounds itself, and that's a risk factor. And I think I guess, however, we should also consider that the folks who go into those professions after serving the military might, in some cases, be very resilient. They might be the folks who were doing well enough to, succeed in those sorts of careers. So, but there's a lot of research on the impact of first responder jobs, including EMTs and firefighters, and how just those types of duties are prone to lead to things like moral injury, which is a newish concept in the field, as well as post-traumatic stress and things like that.
I definitely appreciate that. And I think maybe to follow up on that, and you somewhat referred to this, Lynsay, but I think or I know there's frequently a danger that we think about challenges like serious mental illness or mental illness and suicide risk in veterans, and we assume that all veterans are at increased risk of that, right? To say that veterans are almost universally impaired, especially if you think about combat veterans. I wonder if you would be able to talk to the fact that understanding that this data in suicide is a significant aspect, but this isn't meant to indicate that all veterans are universally impaired, either psychologically or socially or in some way.
Yeah, there's still rare events. So look, we're talking about 44 out of 100,000 versus 27 out of 100,000. So, most people are doing well, the vast majority. Um, but that doesn't mean there aren't things that could be helpful. We all have, depression, anxiety, PTSD are extremely common in both civilian population and veteran population. We talked about some of these issues around homelessness or employment issues that many people can use help with. So there's a lot of room for intervention just to improve quality of life in general, even though it's low risk overall. And like you said, the vast majority of people are doing well and thriving.
And typically, if you did have serious mental illness, you might not even make it into the military, depending on when those symptoms emerge. So generally the folks entering the military tend to be healthier. They get screened for a whole variety of things, including mental health, and so they tend to be healthier at the beginning. So.
Great. Thank you both so much. There's a question here, Lynsay, I believe is related to Reach Vet and Risk ID. Recognizing that you are not a VA employee and do not profess to speak to the VA or about VA programs, but there's a question about how veterans are informed about the use of Risk ID or Reach Vet to identify suicide risk. I'm not sure if you could speak to that.
Yeah, well, for Risk ID, for sure they're aware because it requires them answering questions and they could refuse and not answer those questions. For reach vet, since that's a passive algorithm happening in the background, um, I don't know if everybody's aware. I think VA does its best to be educating, the veteran population, the general public about all of the things that they're doing for suicide prevention. And Reach Vet is very widely disseminated. There's been a lot of information out there about it. That doesn't mean that everybody thinks about, oh, that means that there's this algorithm working in the background monitoring my medical record and potentially flagging me. Um, but if or when a veteran is flagged by Reach Vet, the provider, the staff member who reaches out to them would have a conversation about, when they reach out to offer more support, they would have a conversation about why. But I'm not sure if that fully answers your question.
Right, and I think that that is definitely a question for a colleague who would be at the VA, who is more familiar with that
Yeah.
program rather than necessarily research that
Kind of
program.
kind of hidden in that question is the fact that we do get the impression culturally that veterans are concerned about privacy, and I mean many of us are, and particularly as the more technological approaches are being implemented, it's something that everyone worries about, but there may be also like a cultural issue there with people being even less happy about their data getting used. So that's one of the things I think that needs to get explored for some of these tech solutions, like does somebody want to wear a Fitbit that then, alerts their doctor that they haven't been sleeping well this week? That's not going to be for everyone. But some people, maybe the younger veterans might like it. But it's an open question as to whether or not that's going to be the kind of thing that's appealing or not.
Mhm.
Yeah, and I think that goes back to, I think even as both you indicated, the context of the intervention and sort
Mhm.
of the population. Again, the broad range, post 9/11 veterans range from 20 to almost 55 or older, right? And so I think that especially Global War on Terror veterans, you have a wide multi-generational span there, um,
Mhm.
of which, yes, I am on the higher end of that time frame. Um, Another question, Lynsay, I think that going back to you provided a lot of data, but I'm curious how attendees might use some of this data to inform the development of outreach programs and engagement. Like when you said that younger veterans have higher rates of suicide, but older veterans have higher numbers. I mean, that's data, but how might they use that data to inform their efforts?
Yeah. Well, I if I were in a position where I was interacting with those younger veterans, maybe those are also folks who have recently transitioned out of the military. So that's another consideration. I might be really careful about making sure if I'm a healthcare provider, making sure that I'm doing suicide risk screening and that my staff are trained to know how to manage suicide risk when it emerges. That's good practice no matter what, but especially to attend to those things. And then also, to think about ways to address some suicide risk factors that could look different in those different populations. So, for example, the social connection and isolation that we know is a risk factor for suicide, how to engage younger veterans in social activities could look very different from how you engage an older veteran. Um, I think there's not a one size fits all is the bottom line. So just knowing that those younger veterans are going to be at higher risk and and they might need more tailoring of our existing interventions. Lisa, do you want to add anything?
No, I think that's right. I mean, there have been some efforts lately around the transitioning service members, for instance, because the rates were increasing there in the last few years, and Again, like trying to get people stabilized, not just in terms of their mood and their thought processes and behaviors, but getting them employed and those kinds of things that are really protective. So yeah, I think, like you said, having the data to understand where you want to concentrate. But it's always tricky with suicide prevention, I want to say also, because even though the numbers might be larger in a certain group, the rate might be rising in a different group and really need interventions. So, for instance, the rates uh, among rural veterans might be increasing, and even though it's not that many people, like number wise, that's something that you would really be able to put some effort into if you see the rate is increasing. So the data is really important for informing all of that.
Mhm.
Yeah, definitely helpful. I think we have time for one more question. And the question is probably, and I think definitely, Lynsay, you identified characterization of discharge as a risk factor. And the question really is about dishonorable discharge service members counted in veteran suicide data. But even beyond that, characterization of discharge and even the complexity of that, it's not just honorable and dishonorable, bad conduct, general under honorable, but perhaps you can talk about the importance of understanding characterization of discharge in relation to suicide risk.
Yeah, so there's been some policy changes in recent years. I'm not exactly up to speed on that, but for a while, eligibility for benefits was like a non-starter if you had other than honorable discharge. And now I'm like you said, Duane, you probably know more than I do about all the different nuances to that. But that was one aspect that was thought for some time to contribute to the elevated risk in that group was that they weren't able to access the same resources. Also, I guess the sense of self-worth, perhaps as a veteran, if you get an other than honorable discharge, and perhaps the challenge of connecting with veterans who were honorably discharged and being part of those groups. And this relates back to the social connection, some of those protective factors, like feeling like you belong to a community and you have people in your life who understand you. That could be really hard if you're a veteran and you're the only person, in your life who was not honorably discharged and doesn't have access to those helpful resources. Duane, do you want to add anything as a veteran and
Well, and I
expert?
think some of that is, especially if you have providers who do not have familiarity with military services, understanding that other than honorable discharge is very frequently a decision by someone's chain of command
Right.
in a very immediate, whereas a dishonorable discharge is one that is, adjudication through court martial or even the bad conduct in lieu of court martial. But there's very little difference, perhaps, in some of the behaviors, let's say, that get someone an honorable versus other than honorable discharge. And like you said, there have been efforts related to PACT Act and other things that will allow individuals, regardless of characterization discharge, to access services. But this has definitely been that is like pizza. When you get it, you want more of it, and when you want more of it, then you get more of it, but then you want more of it. And it is very, very complicated to be able to talk about some of these things. But thank you both so much. And obviously, attendees, if you're curious, the resources that we've dropped in the chat are also available for you. Aaron, if we can move forward, next slide, please. I definitely want to thank both of you for joining us today and for the attendees to be able to join us. If you're interested in signing up for the Topics in the News, which is our newsletter from the SMVF TA Center that goes out and gives you some upcoming events, as well as the last webinar in this series, you can do so there. Next slide. We appreciate you and your efforts. You can find the work that we do at samhsa.gov. And next slide. And you can reach out to us at the SMVF TA Center at prainc.com. Thank you again both so much for spending your afternoon with us, and for the attendees, for all of you and your interest in this work and the work that you do to support service members, veterans, and their families. Thank
Thanks.
you all so much.
Have a great day.